host, Maggie Stankiewicz, and I'm pleased to welcome you to today's event. Before we get started, I'd like to give you a little bit of background on Advize Health. At Advize, we analyze processes, implement solutions, and deliver quality educational opportunities for healthcare entities of all sizes. We offer an extensive catalog of services, including HIPAA and compliance analysis, medical documentation auditing services, and educational opportunities for a number of specialty-specific topics. The educational seminar you are about to view is just one of many services that Advize Health's advisory sector has to offer. We provide the medical billing and coding community with 30 free CEUs per year through our monthly webinars and coding newsletter. Our priority and promise to the healthcare community is to always tailor our services to our clients' needs and budget. We have an exceptional speaker for today's presentation, Dr. Phil Smith from MedMorph. Dr. Smith is a dual-boarded physician who accomplishes huge projects, including automating healthcare operations, achieving high levels of physician adoption of these technologies, as well as healthcare operations and analytics. He formerly served as Vice President and Chief Medical Information Officer at the 44 Multi-State Adventist Health System, and most recently automated the H. Lee Moffitt Cancer Center in Tampa, Florida. He is the author of Making Computerized Provider Order Entry Work, which is published internationally. He currently does independent healthcare management, analytics, technology consulting, and is an advisor to medical software companies, healthcare organizations, and to an innovative global medical device company. Now, for some general housekeeping items. There are 2 handouts that have been uploaded for your review during the session. You will see them in the handout section of the little docking bar on the side of your screen. We will be monitoring questions throughout the webinar, so feel free to send them in to all organizers at any time. There will also be time at the end for a Q&A session. This webinar will be recorded and sent to all attendees along with a certificate for 1.5 CEUs within the next 3 to 5 business days. I'll now turn it over to Dr. Smith.
Well, thank you, Maggie, and welcome everyone. We're glad to see a really robust turnout on this topic of MACRA, and this will probably be one of the last times we talk about MACRA because you'll probably hear it known as the Quality Payment Program moving forward. But I'm going to take you through the basics and then get down to the details of the final regulations that were published by Medicare, the Centers for Medicare and Medicaid, or CMS, on October 14th, earlier this month. So most of this information is only 13 days old, and I hope you get a lot out of it. There will be time for questions at the end, but because of the complex nature of this, I encourage you to get clarity on any point that you might find that you need clarity during the presentation. So if you'll feed the questions in, Maggie will let me know there are questions, and I'll pause and be glad to address them. Also, this is recorded, and we hope that you take advantage of sharing this with people that need to know. So let's moving on now. We're talking about MACRA today, and MACRA is, we're going to review it and talk about what it is, and it's discuss the payment options for physician offices under MACRA and understand the pros and cons of the new payment system. So the formal name MACRA comes from the acronym for Medicare Access and CHIP Reauthorization Act of 2015. And this is a statutory regulation. So this is, a lot of people's first question is, will this be impacted by the presidential election? And the point is that this was a statutory action of the Congress, and it was a bipartisan bill, and it was intended to get away from the every year Congress had to do an adjustment to physician payments, which we'll cover here in a moment. And so they wanted to do a comprehensive bill. And so MACRA was a result of that, and in that it is statutory and coming from the legislative branch of government, it will not be affected by the presidential election coming up here shortly. So this is going to be a major change in how payments are done to physicians and physician extenders. And going forward, it'll be known as the Quality Payment Program, or QPP. So just to be clear, MACRA is the name of the legislation, and QPP is the name of the program. So much like a few years ago in 2009, the Affordable Care Act and Patient Protection Act was passed as legislation, the functional name for it has been Obamacare. So this is a new program, MACRA, turning into the Quality Payment Program. So first off, a lot of people don't know what all these words stand for, and I think most people understand that Medicare is a federally funded program run by the federal government. It covers adults age 65 and older, as well as those Americans who are permanently disabled under Social Security income, or SSI. So they are eligible to get Medicare as well. So a lot of times people think Medicare is only for people 65 and older, but it does cover people that are permanently disabled under the federal program. CHIP, on the other hand, is the Children's Health Insurance Program that's been around for about 20 years. It covers children up through age 18, and it's intended to help provide insurance coverage for families who make up to $48,600, although some states have put their own money in to allow that to go up to a higher income cap. And most people don't know that CHIP is also covering, was legislated for U.S. citizens, but by presidential decree of the DREAM Act, that would include anyone born in the United States automatically gets U.S. citizenship, although that was not legislative act, that was under executive order, so that could change. So today, though, in reference to MACRA, we're only going to be dealing with the Medicare part of MACRA and not dealing with the CHIP program at all. So there are three important changes to how Medicare is going to pay providers, and the goal of the plan is really to have 25% of physician reimbursement covered under the Quality Payment Program by the end of 2018. So those are important numbers to remember, 25% and by 2018. So the program, as I said, is going to be known as the QPP, or Quality Payment Program. And if you want very specific details, and if you want to read the over 1,500-page bill, you can go to qpp.cms.gov, which is the official website of the QPP. So as I said, it was a bipartisan bill, and it was enacted to end the Sustainable Growth Rate Formula, or SGR. And this was basically under the Budget Reconciliation Act. There was actually a freeze on Medicare reimbursement to physicians, but Congress has every year dealt with the SGR and built in a special bill at the end of the year to increase the rate of office visits. And so rather than doing this fix every year, Congress decided to create an entire program, and we're going to go into great detail about the specifics of this program. The goal of the program is to allow a framework for rewarding physicians and physician extenders, so those are PAs, physician assistants, nurse practitioners, for giving, quote, better care. And it's really only affecting doctors who are paid under the fee-for-service payments, and will not affect HMO payments, Medicare Advantage, and other capitated programs, which we'll deal with. And it's paying more for quality of care rather than for volume of care. So today, physicians are billed for the number of office visits and the complexity of the bills, and so that's called pay for fee, pay for volume, and this will be pay for performance, which is looking at your quality numbers and improving the quality of care that you're doing, or at least that's the vision of the program. And it takes 3 other programs and combines them into one system. And these programs have been around for quite some time. The PQRS, if you don't know that, is a physician quality reporting system. And this requires physicians to report their compliance with certain quality measures such as immunizations, pregnancy care, vaccinations, diabetes care, and such. The Meaningful Use Program was part of the HITECH Act, which came as, from the 2009 stimulus plan, and turned out to create incentives for adoption of electronic medical records. And about 66% of physicians by the end of last year had adopted digital health records in some form or another and received incentive payments for that. And then the last is called the volume modifier, or VM, and that's been a value-based payment modifier available to some physicians. So the Quality Payment Program, or QPP, is going to have 2 different models. The first is called MIPS, and that stands for Merit-Based Incentive Payment Program. And this will be the most common entry program for physicians and physician offices to get into the QPP. The other is called the Alternative Payment Model, or APM, and that will only be eligible to physicians who are already involved in alternative payment models under Medicare. And I'll explain those differences in a few moments. So if you're representing a medical practice and you're currently doing fee-for-service and you do not have an alternative payment model, you're really going to want to pay attention to MIPS because probably 95% of physicians will be participating in some types of MIPS-based program, ultimately to try to develop not only a MIPS, but to develop an alternative payment model. And I'll explain both of these in details. The goal of APMs, though, is to create some very interesting pilots around quality and come up with some new innovations. And CMS, which stands for the Centers for Medicare and Medicaid, has an innovative center that has been trying for years to come up with unique ways to move our health system, at least the Medicare portion, from pay for volume into the pay for performance. Now, if you go to the website, it says participation in these 2 models is voluntary, and that's what it says in the law. But non-participation in 2017 will mean an automatic 4% penalty into the 2019 reimbursement to any physicians who will be under this act. So I think it's interesting that the legislation says voluntary, but the implications are that if you don't do it, you're going to take a 4% cut. So imagine if your employer said to you, we're doing a voluntary program at work, and you're welcome to not do it, but you will have a 4% cut in your salary or your paycheck starting in 2 years automatically and going up to 9% if you choose not to participate. So it's a new definition of voluntary. The final regs, as I said, came out 2 weeks ago tomorrow on the 14th of October, and they take effect on January 1st, but you can delay start of MIPS participation as late as October 2nd of 2017. So you essentially have from now to 2 months to capture a bonus for MIPS in 2019, but if you delay till October of 17, you can avoid a penalty if you do 3 months of participation, but you will not be assured any type of a bonus based on your payment. And remember, I want to be real clear. What you do in 2017 will set the stage for how you get paid as a physician in 2019. So your actions are always going to be rewarded or penalized on a 2-year delay. So what may not be of interest to you today may be a big interest 2 years from now. The other thing is, for meaningful use, we had a concept for what was called eligible providers. And those were the physicians who had to apply under meaningful use. And certain physicians who were hospital-based were excluded from meaningful use benefits and from meaningful use penalties. And there was a hardship exclusion. And that will go away under the QPP. And eligible providers will essentially be anyone that does office visits, outpatient visits, surgery visits, or is a telehealth provider. And telehealth is when you do virtual visits, and that'll be a new concept. So if you're patient-facing, you will be impacted by the QPP. Now, the non-patient-facing physicians who will not be impacted from this will be typically pathologists who do not do procedures, radiologists who do not do procedures, and anesthesiologists who do not do procedures. However, in each of those fields, there are people in each of those categories that do office visits, such as an interventional radiologist, who do essentially surgery in the radiology suite, anesthesiologists who do pain management and do office practices, and pathologists who might be doing office procedures such as fine needle aspirations of the thyroid and similar proceduralist pathologists. So it's important to understand that this will impact people. This will not be impacting the hospitals per se, but this will be totally impacting the professional services or physician pay, whether you're a MD or DO or a physician extender, such as a certified nurse, anesthetist, a midwife, a physician assistant, or a certified nurse practitioner. And CMS will annually publish a list of codes, and you are exempt from reporting if you do less than 25 of these types of visits in a reporting period. And again, the reporting period is 1 year. So it would be very hard to be a practicing physician and not be covered by this unless you are not a Medicare provider. Now, as I said, so we're going to break in to discuss MIPS before going into the alternative payment model. So MIPS, as I said, is basically the gateway drug or the entry level into the quality payment program. So it combines these various acronyms into a single program. There are 4 metrics that are to be covered: quality, resource utilization, which is cost, clinical practice improvement activities, also known as CPIA, and meaningful use of certified electronic health record technology. And so we'll break down how much of these are involved for each year, but Maggie says we have a question. So since I'm just getting into MIPS, let's take that question because that's the overview of the program. So Maggie, what's our first question?
We have, you said that there are no exemptions, but in the rule it states that you are exempt if you meet certain criteria, such as Medicare patient threshold. Can you confirm or deny which of those 2 is true?
Yeah, I will cover very specifically the people that are excluded, and I'll have a slide on that. And so let's leave that for a moment. So physicians in their first year of practice as a Medicare provider will be excluded, and certain low-volume people and people that do not do Medicare fee-for-service. So they would not be, if they don't participate with Medicare fee-for-service, If they have a very low volume, which is less than $30,000 a year in Medicare billing, less than 25 visits a year, or in their first year of practice. And I've got a slide that breaks that out. But that is actually a very small number of physicians who are actually excluded from the program. Any other questions right now?
Let me see. It looks as though we have one more that says, do new physicians start at the base fee?
Yeah, so we'll get into the base fee specifically on where we're at, but because the bump up that has happened every year by Congress, they are doing one more bump up of 0.5% over the 2016 reimbursement numbers, and then after that, physician fees will be frozen. So if you don't participate in the program at all, you will basically be living on 2016 reimbursement values. So whatever your CPT or your EMM codes are this year, there'll be a 0.5% bump for next year, and then that those 2017 rates, which will be 2016 plus 0.5%, will basically be the baseline that everyone entering Medicare will be on. These are good questions. Obviously, some people have some familiarity of it. But the devil's in the detail. We'll get down to that very specific detail. Okay, I think the biggest news from all of this, though, is that reporting is going to be done by the tax ID number and not by the physician provider, which meant that under meaningful use, if you had a 50-physician group practice, you had to present the data for each of the physicians independently. So you had to track a variety of measures and report physician by physician. So under QPP, the one benefit is the tax ID number will be the reporting entity for this. And that is probably going to lead some physicians to actually join group practices to avoid having to all the record keeping to do this. So let's hold on a question, Maggie, for a few minutes. Let me go through the basic of MIPS, and then we'll take some questions on MIPS. So this was what was originally proposed, and this is not what the final regs came out with, but I wanted to give you an idea of where we were at a month ago, that with these 4 measures, quality, advancing care information, or ACI, which replaces meaningful use, CPIA, which is clinical practice improvement activity, and then the resource use or the cost. They originally published that it was probably going to be half would be quality, and the other 3 would break it up into it, and then the quality measures would be less and the resource use would go up. But with the published rule that came out 2 weeks ago, they have moved quality up to 60%. Advancing care, or ACI, which replaces meaningful use, is now 25% of your points, and improvement activities are at 15%. And to make it real easy, there are basically 100 points that you can potentially earn. So 60 of those would be in quality, 25 would be in advancing care, and your improvement activities would be 15%. And there is no cost factor in the first year. And we'll explain that here as we break this down to a little higher detail. And this is from the published QPP site that just came out. So if you look under quality, as I said, that replaces the QRS. Most participants will have to report up to 6 quality measures, and they'll need to do it a minimum of 90 days to avoid penalties. And if you do 90 days, you will have access for a little bump in reimbursement, and if you do the full year, you'll be eligible for the full 4% bonus in 2019 if you meet the threshold. groups that use the web interface to report PQRS today will need to report 15 quality measures for a full year. And then there are groups that are already in alternative payment models, and they will have special scoring under MIPS if they're under Shared Savings Track 1 or the Oncology Care Model. And I will drill down to those in a little bit here because most people don't know what I mean by Shared Savings Track 1 or the Oncology Care Model. Now, under improvement activity, you'll need to attest to up to 4 improvement activities, a minimum of 90 days. And again, there are some alternatives if you're going to be under APM. Under the ACI, or Meaningful Use Replacement, you'll have to do a security risk analysis. You need to be doing electronic prescribing of your prescriptions, your non-narcotic prescriptions. You'll have to have some type of patient portal access. You'll need to be able to send a summary of care to another provider by secure email, and you'll need to be able to accept a summary of care from another provider. So these are new, this last one, accepting it. In 2016, you had to be able to send a summary of care, but you did not have to be able to accept a summary of care from another doctor. And then there's some bonus credit if you report to a public health or clinical data registry. And as I said, the doctors will not have to submit any cost data. That will be calculated as a result of the claims that you submit. So that's what's meant by adjudicated claims. That means claims that have been processed and paid or denied. And in 2018, the cost data will start appearing and will be 10% of your bonus. So what are clinical practice activities? Well, any of us that are specialists, and I'm actually boarded in 2 specialties, family medicine and in clinical informatics, we have to do clinical activities every 3 years to keep up our board certification. So physicians are familiar with doing clinical practice improvement activities, at least if they're board certified and not grandfathered in. But these will actually be quite a few that they'll need to do. So they'll need a score of 60 points in this section, as I noted. And activities are either considered hard ones or medium ones, and they're scored at either 20 or 10 points, with the higher ones, rated ones, being a little more difficult to do. They have 90 different choices, and physicians can innovate and pick things outside of these, but there are 9 general categories, which I'm not going to read to you, that they would like to see physicians engage in. And I'm going to break these down into the 4 areas you need to do. Now, there'll be special rules if the physician is in a rural practice, if they're in groups of 15 or less providers, if they're practicing in a health professional shortage area, which are underserved areas defined by the federal government, if they're non-patient facing, as I said, if you're not doing patient care, such as an anesthesiologist only working in the operating room, you won't need to do this. If you're already a patient-centered medical home site under the federal program doing risk sharing, you will be excluded and you'll be covered under the alternative payment model. And if you will get automatic credit even if you do MIPS under that model, and if you're part of the alternative payment model otherwise, and we'll talk about who those apply to. So this is pretty complicated, and as you can see, there are a few exclusions that people will need to pay a particular attention to on whether or not they're defined as a rural practice under federal law. Now, what are shared savings programs? Last month I talked to you about accountable care organizations, but I didn't go into this level of detail. And there are basically 4 different programs that are carried under Medicare Shared Savings Program, or the SSP. And as of second quarter of this year, there were 433 accountable care organizations. These originally started with 19 pioneer ACOs, of which most of the organizations have quit participating with it because the organizations actually lost money. And so they, even though they showed improvement in their own health systems, the way they were benchmarked, if you were in a high-cost state, it was very difficult to show cost improvement. So the way the program was administered has really left a lot of the pioneer ACOs to withdraw. And I'll explain a little bit about what pioneers are in a moment. But under Shared Savings Program, currently of the 40 million Medicare beneficiaries, 7.7 million beneficiaries are covered today under Shared Savings. And so physicians that do a Track 1 Shared Savings Program, they will not get a free pass under MIPS. Track 1 is a one-sided program, and most ACOs, as you can see, are one-sided. And so what does that mean? That means that basically certain dollars that are paid to the accountable care organization are withheld by Medicare until the end of the fiscal year. And then at the end of the fiscal year, they look at whether or not you saved money. And if you saved money, Medicare and the ACO will split the joint savings. So let's say they estimated that your ACO was going to cost $10 million to cover 1,000 providers, and as it turned out, it cost $11 million to cover those 10 million, or those 1 million patients, or 1,000 patients. I'm sorry. So you actually had cost overruns of $1 million. Under a Track 1 ACO, Medicare would accept that $1 million loss and not bill the ACO. And you basically would lose your withhold, but you would not lose any additional money from beyond your withhold. However, if it turned out that it cost $9 million to care for that budgeted $10 million of care, that would be a $1 million of savings, and Medicare would split with you half of that. So the ACO would have a $500,000 bonus, and Medicare would keep the $500,000 bonus. But if you're in Track 1, you don't get the you don't take the risk, but you do have a small upside of 50%. Now, in a Track 2, it is a risk sharing, and you're at a 60% benefit risk ratio. So if you save money in a Track 2 ACO, you get 60% of the joint savings beyond the withhold. And if you lose money, you have to make up the 60% loss, 60% of the total loss, and Medicare covers 40%. And as you can see, only 1% of the ACOs are in this category. And then Track 3 is actually a 75% risk sharing, where the ACO is taking a 75% upside or a 75% downside. And then there is one final program that's usually done at the state level called the ACO Investment Model, or AIM. And some states, like the states of Delaware, have actually done this, and that represents a total of 10% of all ACOs. If you notice, though, the 100% is in these top 3 models. The CMMI are really bigger programs, so I'm not double counting them. They're actually included in the ones above. So what does MIPS mean for you if you're a doctor who's not excluded from MIPS? So there's a pot of money that Medicare is going to pay for physician payments for fee-for-service. That will be bumped up by 0.5%, as I said. And what happens in 2017 will determine what the payments are for the physicians in 2019. And this is a budget neutral program. So what that means is there's a 4% upside, but that 4% upside has to be taken from other physicians who do not participate in the program. So basically, if there's $100 in the program, $4 will be set aside for every $100, and the winners will get $4 extra. The losers will get $4 less. And some people will come out in the neutral phase. So, and then that goes up 5% plus or minus in 2020, 7% in 2021, and 9% in 2022. So this is pretty significant impact if you choose not to do this and you're not one of the exclusionary factors. So it's really, really important to understand and not assume that you have an exclusion. So here are the three major exceptions to MIPS. So if you're in your first year of Medicare participation, you will not be subject to any MIPS adjustments. If you're eligible for the alternative payment models and you qualify, then you won't be covered by MIPS because you're covered by the more lucrative APM model. And if you're below the low threshold, the low volume threshold, as I said, is less than $30,000 in billing to Medicare, or less than 25 office visits in a year of the qualified office visits. So, and obviously those are Medicare patients, office visits, not 25 total patient visits. And again, MIPS does not apply to hospitals or facilities, but it would apply to physicians who are employed by hospitals or facilities. So this is not hitting hospital reimbursement. This is hitting what we call the Medicare Part B, which is the physician reimbursement numbers. Okay, so that's the skinny on MIPS. So let's stop and see if there's any questions about MIPS. And as I said, it is anticipated that they want to see by 2018 25% of the physicians to be enrolled in MIPS, which means they want the rest either in the alternative payment model, which will be a very, very small single-digit effect, and the vast majority of physicians will probably be neutral or penalized under the 2017 plan. So Maggie, do we have any questions?
Yes, we do. We have one question here that says, is this MIPS program on which all physicians are auto-enrolled, or is it something that they'll need to enroll in?
Yes, a great question. And, you know, I don't know the answer to that, but I believe the correct answer is you will have to enroll in it. And you, as I said, you have to enroll by October 2nd of 2017. If you do not enroll, you will automatically take the 4% hit in 2019 payments. So I actually did know the answer to that. So the real question is physicians who are going to be confused as to whether or not they're excluded or not. And the exclusion factors are really quite minimum for anyone who's been in practice more than a year. Other questions?
How will this program affect, if at all, to radiologists and perhaps other specialties that do not do meaningful use?
Yeah, so as I said, the meaningful use criteria are quite different because most radiologists were excluded under meaningful use, although some did take advantage of it and got the bonuses. most were able to get an exclusion to themselves. So the bulk of radiologists who are going to be at risk are those who actually do office procedures or surgical procedures, and that would be typically your interventional radiologists and a certain small percentage of specialized radiologists, such as a nuclear medicine physician who sees patients to determine in consultation a dose of radioactive iodine, someone that does surgical procedures in interventional radiology, and they know who they are. So they are basically radiological surgeons. And as I said, surgical procedures are covered. So every year you'll need to check the CPT codes on the QPP site and determine if there's any CPT codes that are in your wheelhouse that you are doing that are going to be under MIPS. And those will be published, they guarantee that they will be published no later than November 1st of the year prior to the determination. So you should see on the QPP website by November 1st the specific CPT codes that will be eligible for MIPS. And these would include your EMM codes, which are your office codes. Evaluation and management is what that stands for. And your surgical office visit codes, which are usually bundled to the surgical procedure. So please, if you're a physician or a coder physician, check the QPP website and put a tickler on your file every year to go in November 1st and update what the new codes will be for the subsequent year.
Great, thank you.
Any
we
other
have
questions?
another one here. Yes.
Okay.
When looking at measuring quality, how will patients that have more complicated comorbidity be counted? And is there some way to consider patient compliance impact with their patient care health outcomes?
Yeah, that's a great question. So the quality programs are really around what the physician does and the programs that they put together. And they did not address patient compliance with any of this, which is obviously a very difficult thing. As a physician, you would love them to figure out how we, get patients involved to actually make changes. So the first years of the program is really going to be more about operationalizing the quality programs within your practice and getting patients enrolled in your program. It does not necessarily mean that patients have to see the benefits. But in the first year, you're merely going to be reporting what you're doing. And as this program goes on, you will be reporting actual outcome data. So that is subject to change. But in 2017, you really want to be thinking about the types of programs you want to be doing, set those up, and start enrolling patients as fast as you can into those programs so you hit the thresholds to be successful. And don't worry so much about results the first year. It's really about changing the way that you operationalize your office. And CMS has a video I'm going to show you in a minute that will kind of play to this and give you some ideas. Any other questions, Maggie?
We have one more that says, is there a site that lists what the alternative payment models are besides ACO?
Yes, I've got a listing of that, and that is on the QPP site.
Okay, great.
Okay.
That appears to be all we have for now.
Super. Okay, let's talk about alternative payment models. So this is an entirely new scheme for fee-for-service physicians. And quite frankly, there are two programs within an APM. And if you already have an accountable care organization in place, you're going to want to try to get qualified for an APM. So if you have a federally funded or federally qualified or recognized patient-centered medical home or PCMH, you're definitely going to want to go for the APM. If you only have a MH that you designed or hasn't been recognized nationally, you're still going to want to use that, but you'll probably apply that towards your points for your MIPS score in the first year, because the real PCMHs in APM are really the ones that take risk. So those are what we call the two-sided risk models, are the ones that are really eligible for the APMs. And there are some bundle payment models. The most notable one is impacting orthopedic joint replacement surgeons. And so there is a program for total knees and total hips where there's a bundle payment program which basically pays one fee to the hospital and to the surgeon for the entire 6 months of care for joint replacement patients. And that will be a program that will qualify you potentially for an APM. So if you work in an orthopedic practice, you're definitely going to want to get involved with that if you're under the joint bundles. The way this works is from 2019 to 24, they're going to pay a lump sum incentive payment, and for anyone that's under the APM. So as I said, this will be upside and not downside. So this is a very lucrative program that they've actually put some pretty significant money into. There will be a lot of transparency around this, and they have guaranteed that by 2026 they'll actually be significantly increasing payments to people under the APM. So so if you can read the writing on the wall, if you're a physician or a physician practice manager, you're going to want to, if you're already involved in a two-sided ACO, you're going to want to keep that up. If you're not in a two-sided ACO, you're probably going to want to do a one-sided PCHC and start your work towards getting qualified in the next 6 years as an APM. Because that's where the money's going to be. And like I said, even though it's a voluntary program, if you don't participate in this voluntary program, you will basically be on your 2017 fee schedule for the rest of your life with a 9% withhold from that current amount. So with the rate of inflation in healthcare, you can imagine it will be hard to be practicing medicine for fee-for-service in the mid-2020s without getting involved in this program the way it's laid out. So there is an advanced APM provider, and there will be an additional 5% bonus on top of the APM bonuses or incentives. So that is going to be a very select number of providers. Again, these are people taking shared risk at track 2 or track 3 level, and some innovative programs, but you'll want to pay attention. That's the category that you really want to work to. So let's drill down a little bit into this. So this is a whole new way of paying. Under section 1115A, there's the Healthcare Innovation Award, which is put out by the CMS Innovative Center. And if you go to cms.gov and go under Innovation Center, you can begin to look at the details for this. As I summarized the MMSP a little bit ago with the where they have the track 1, track 2, and track 3. And then you can actually do a demonstration project and actually come up with your own quality demonstration program. But that's going to be very difficult for people to do. Now, MACRA does not change how particular APM rewards value. And if you do an APM participant but don't qualify under the APM rules for reimbursement, you'll be able to apply that to your MIPS score which will likely get you into at least a small bonus. So I would be thinking about APM, even though it's not something you're going to be able to jump into if you're not already doing it. Let me go one more slide, Maggie, and then we'll stop and take a few questions. So the qualifying participants, they will not be under the MIPS program. So if you think about it, under QPP, there'll be two programs. There'll be the MIPS, which will be the bulk of most people, and then some people that are in the alternative payment models will actually be qualified to get into the quality participants and be classified as an APM or an advanced APM. And as I said, those rewards are substantial. So eligible APMs are the most advanced APMs under the quality law. And as I said, the quality measures are comparable to those in MIPS. You'll have to do the ACI, or the meaningful use replacement. So you'll have to have an electronic medical record. You cannot do this if you don't have an electronic medical record. And you will have to be at risk financially. So if you are not willing to do track 2 or track 3 under medical shared risk, you will not be eligible for APM unless you're under one of these very unique medical model homes, as I said, under the CMMI. So for instance, the state of Delaware, if you go to their website, they have a CMMI authority under the state of Medicare, under the state of Delaware to participate. I'm in the state of Florida, and there is no CMMI authority in the state of Florida. Okay, so let's take a break here and get a few questions in. And I'm not done completely talking through APM, but we'll deal with a few questions.
Our first is, what are the implications of MACRA from a program integrity perspective?
I'm going to need more clarity on that question. So if the person could reframe that a little bit.
Okay, great. In the meantime, we have another question.
I will make a comment, though, of what I said, because the implications of that is that maybe this won't happen. And I said up front, and you may have joined late, that this is a statutory change in Medicare. So this was passed by Congress. It has nothing to do with the presidential election. It's not executive order. It's not something by the Department of Health and Human Services. So this program is going into effect January 1st of 2017. It is unstoppable at this point, and it would take an act of Congress, which is not going to happen, to further delay this program. So don't confuse this with other things that are out there that may or may not happen on such and such a date, because many people said, well, you know, ICD-10 got pushed back a couple years, and at the last minute they passed it. Well, the last minute was October 14th when they published the final regs. And this ship has left the port, and this will be the way we're doing business starting January 1st, again, affecting your 2019 reimbursement. Okay, next question.
Next question is, if you participate in an ACO, does MIPS run through the ACO or through the individual physician practice?
Yeah, great question. So remember that you will be submitting this data under your tax ID number as a provider. Now, many of the ACOs will help you collect the data and submit the data, but you will still have to register under your tax ID number to make sure you do that. So you will want to specifically go and register as soon as possible, because if you're in the ACO category, you want to start this program by January 1st, because you have the potential to get the full year incentive payment, and you do not want to delay signing up for this. So I would say you want to do that in the next 60 days and not miss the January 1st enrollment time. Now you do have till end of March 2018 to submit your data for 2017. But please get out there and enroll. And if you're in a patient center, if you run a patient-centered medical home or you're part of an ACO, speak to your ACO administrator and get a strategy together, but make sure that your tax ID number under your practice is registered for one of these programs. Go ahead.
Let me see here. We have a comment that says, you mentioned that physicians and ACOs were excluded from this program. Can you clarify?
No, I didn't say they're excluded from the program. I said that people that are in at-risk ACOs should try to get recognized as an APM, and if not, at least get into the MIPS, because if you are involved in an ACO, you're probably going to be able to benefit from this program. So I didn't say anyone in an ACO is excluded from this program, so that's a false statement. So if I scrambled my words and said that, I apologize, but this impacts any physician who sees Medicare patients who are not in the first year of practice, does office visits or surgical office visits, any qualified CPT codes, and does at least $30,000 of Medicare business a year.
Thank you. That appears to be all the questions we have at this time.
Thank you, Maggie. So, how do I become a qualifying APM? So, beginning, you really want to, first off, you want to register your intent that you want to make sure that you meet the threshold for the percent of your patients who are eligible for payments through the APM. And those will probably change every year. So go specifically to the website and look at all the details to get those. And the interesting thing that after this program is in effect a few years, they're actually going to expand it so you can include on your threshold patients who are non-Medicare payers, such as patients under the age of 65 and patients on Medicaid. So this will get interesting on data submission, but remember, for the first 2 years of the program, this is only about your Medicare patients. And that's going to make it interesting as well, because they have not defined the meaningful use criteria for Medicaid patients, because meaningful use is still in effect for providers who see large numbers of Medicaid patients. And remember that if you're a qualifying participant of an APM, you're not subject to MIPS, and you will actually get another 5% lump sum bonus payment for 5 years on top of it, and you'll be able to receive a higher fee schedule going forward from 2026 on. So this is really where they want to move as many participants as possible. So what are some of the models of advanced APMs? And this came out on October 14th, so this is the list. So first off, there's a program called the Comprehensive End-Stage Renal Disease Care, abbreviated CEC. That's a two-sided risk model. So this is people that take care of patients on dialysis. So that is an interesting program. The new CPC Plus program, which is Comprehensive Primary Care Plus, and I would probably have to talk for 2 hours to explain that to you. But they put a large dollar amount into this program to help primary care doctors. This will mainly be family medicine, internal medicine, people that deal with the geriatric population, perhaps some people in OBGYN, but probably not the OB side, more the GYN side. If you qualify under a next generation ACO model, which are being defined, as I said, if you're in a Track 2 or Track 3 shared savings program, and I said before the risk was 60% and 75%. I'm corrected at 60% and 70%. Track 1 is 50%, and as you see, shared savings program Track 1, where you do not take risk, does not qualify you for an APM. So that's very, very important, or an advanced APM. And then there's a new oncology care model where it's an at-risk model. And so that is going to be a very interesting model. Now, I was going to take a break from talking, and if you don't know what rainbows and unicorns are, you're welcome to go out to Urban Dictionary and check that out. But this is the way that the quality payment program, I'm going to show you a short little cartoon that was put out by the Centers for Medicare and Medicaid earlier in the year to kind of sell this to physicians and practices. So it does cover the philosophy pretty well on the program, but it may be a little exaggeratory of how easy it's going to be. So let's watch this together, and then this will be a good time to submit questions to Maggie so we can address after the video.
You trust your doctor with your most important health session, and rightly so. In America, we're lucky. We have some of the best doctors. Right now, our healthcare system often makes it difficult for them to practice medicine the way they think is best. In many hospitals and clinics, if your doctor wants to take the time to sit down with you and learn more about your health, or help you understand your care, she doesn't get paid. If she wants to try a personalized approach that isn't on a predetermined list of services, she doesn't get paid. And there's often no way to pay her for doing the work that we know keeps people healthier, like preventive care and educating patients to live healthier lives. Instead, our system pays for tests, treatments, and procedures. Saw 30 patients in a day? Check. Did a biopsy? Check. Read an x-ray? Check. Not surprisingly, this has led to more services and higher costs, and it often leaves doctors and patients unsatisfied. Over the years, different programs have tried to make things better, but change was sporadic and fragmented. We have made progress, like helping the vast majority of doctors adopt electronic health records, but some of the requirements were too complicated or complex, and the fundamental goals got lost. Many doctors were frustrated, and some couldn't or didn't want to take part. To help fix this, Congress recently passed a bipartisan bill, supported by doctors and medical groups, to change how we pay for care. This new effort is called the Medicare Quality Payment Program. Instead of payments that encourage assembly line style of care, this program helps doctors focus on quality and the one thing that matters most, whether patients are getting healthier. Here's how. First, it replaces our patchwork collection of incentive and penalty programs with a single one. And though we will still pay for services, every doctor will have the opportunity to be paid more for better care and investments that support patients, like creating a helpline or having nurses follow up at home. And for doctors who want to go further, there's a second option that's even more flexible. They can decide to be part of new organizations that get paid primarily for keeping people healthy. For example, they could be part of a health home, where a team of doctors work together to meet a patient's needs. On this track, doctors can help patients understand prevention and wellness. They can try innovative approaches like telehealth or nutrition classes, and they can focus on keeping people healthy. We are working with doctors, insurers, health organizations, and patients to make sure we find the path that works, one that's simple to use, pays for better care, and keeps important programs like Medicare sustainable. These kind of smarter payments give doctors more freedom to practice medicine the best way they know how. They take people off the assembly line and put them in the center of their care, and they are key to making our system work better for everyone. To find out more about other efforts like this, go to hhs.gov/delivery system reform. Better, smarter, healthier. This is the future of healthcare in America.
Okay, so as I said, that's a very...
Your medical group,
Whoops.
business as usual isn't usual anymore.
Let me get out of that.
Revenue came from the number of services provided. The more services your group did, the more you made. For years, you've heard that volume is out, value.
Okay, I got foiled by YouTube. Going to the next video. So as you can see, every doctor was smiling, every patient was smiling, everyone was happy. And like any major change in the way people get paid, I'm sure if your employer came to you and said, I've got this new scheme to make you a better employee, and if you do a good job, I'm going to bump your salary in 2 years, and if I determine 2 years this year that you didn't do a good job, 2 years from now I'm going to cut your salary, you probably would be a little suspicious, concerned about the impact of it. So there will be a lot of fear and trepidation about this program. Certainly the intent of Congress is very altruistic, but as we know, often with government programs, there's a bit of overpromise and under-delivery. So we will have to be a little skeptical of how this all plays out. But like I said, it's important for us to be informed to know. So what are some of the concerns about the quality payment program? People in small practices are very concerned that there'll be difficulty earning incentives if they do enough Medicare volume to do it. So it may or may not drive mergers of independent practitioners and small practices into larger practices and into insurance-run ACOs for the ability to try to reduce the burden on reporting all of this. And the second point is there will be a huge reporting burden on the industry. It doesn't mention at all in the video that it shows all the paperwork going away, but the fact of the matter is all of this will have to be documented and reported to the government, and those reporting systems will have to be developed based on final rules that were just published 13 days ago. The quality metrics will tend to be very imprecise because the first year of this program will be a learning curve. But because it is budget neutral, the fact is it's legislated that in 2019 there are going to be winners and losers. So they have to take money away from some doctors in order to give the money to the doctors who do figure this out and do it well. And so being budget neutral, there's no pot of money to track into. And so it's going to be very interesting how it goes. It does not address other plans like Medicare Advantage plans. It's not clear yet how Medicaid meaningful use is impacted because there's still the Medicaid meaningful use requirements for reporting. So if you're a Medicaid provider, you still will have to deal with that. And as I said, it is budget neutral, which means there will be winners and there will be losers. Now, this is the timeline that was actually published on the Medicare website prior to the final regs coming out. And as I said, there is a 0.5% fee upgrade that did get approved for 2017 for that 1 year. The advanced APMs, the 5% payment, incentive payment is holding, and the plus or minus 4, 5, or 7% is also. Everybody's calling me right now, so sorry for that. So just to break this into the 3 categories, so and then I'm going to break it another way so you can figure out based on the final rule where you really want to fall on this. But if you think about it, there's the MIPS only, where you have the MIPS adjustments, and as I said, 60% will be based on quality, and I gave you the other percentages. You'll have the advanced APMs, which are the people who are already doing alternative models and getting paid for it. And then there'll be some people that don't quite, will go for the APM track, but don't quite qualify for the advanced APM, but they'll get a very good MIPS adjustment based on participating with the APM model. So that'll be really good. So here is the algorithm. So if I'm already an advanced payment model provider, and I do a lot of patient-centered medical home, I'm in track 2 or track 3 ACO, I'm probably going to be an eligible APM, and I'm probably going to be good and sitting pretty. If I'm not in an APM and I'm not excluded because I'm in my first year or I'm a low volume person, I'll be subject to MIPS, and I'll want to take advantage of the MIPS program. So this is kind of a summary of what came out of the final rule. Now that I've given you all the foundation. So there are 4 new options out of this, but there's kind of 6 different caveats. So the first thing is that 2017 is going to be considered a transition year. So you do not have to report a full year of participation to avoid penalties for this voluntary program. But remember, we're talking about 2019 payment based on what you do in 2017. So you can choose to not participate, you can choose to partially participate, or you can choose to fully participate. So we're going to break that out a little bit. So if you submit some quality payment program information in 2017, you will not have any penalties in 2019. So you'll be at basically 2016 fee schedules plus 0.5%. And you won't have the 4% penalty against you. If you submit less than a year, you won't have a penalty. But if you submit and you get over 70 points, and remember 60 points are for quality, there's an additional $500 million of money that's been set aside for what are called the exceptional performance MIPS people. So that's new money that's available considering that there's a Medicare freeze for everyone else other than the 0.5%. And then the physician groups that submit information for a full year, they will get a modest improvement in payment. And most people feel that that will probably be 2 to 3% of your Medicare base. And if you're a real high performer, you'll get the full 4%. But most people will be looking at what they call a modest payment, or a 2 to 3% bump is what we're talking about in the industry. And then those who participate in track 2 or 3, in other words, a shared risk Medicare savings track 2 or 3, you will probably be able to get the full 4% bonus. And as I said, all physicians who participate with Medicare, even people in their first year of practice and people that don't make the threshold, will get a 0.5% bump off their 2016 rates, which there was some concern with the sustainable growth factor taken out that there might not be any raise in rates from 2016 levels. So specifically for MIPS, from the proposed tables that I showed you, remember quality was proposed to be 50%, they increased it to 60%. You only have to report on 6 quality measures. Previously you were going to have to report on 9. And the quality measures have to, are selected annually by November 1st. So that's going to be important to know. So those should be publishable by next week. The ACI, which replaces meaningful use, will be 25% of your calculation, or 25 points for 17. You only have to report on 4 required measurements, and you only have to report for 90 days. And previously you had to report for 18 measures for a full year, and you had to meet it for the full year. Remember, under meaningful use, you had to submit data at the provider level, not at the practice level. And then for these new clinical improvement, patient improvement and activities, that's only going to be 15% in 17, but that will continue to increase each year of the program and be taken from the quality scores. And those who are MIPS eligible with a certified patient-centered medical home, they will receive the highest score because they will get 60 to 70 points on MIPS. So that'll be a very good deal if you do a patient-centered medical home, even if it's not an at-risk model. And as I said, they have expanded the definition of PCMH. There's a reduced number of elements. So before you had to either submit 6 medium weighted improvement activities or 3 high-rated activities, but now you only have to do either 4 mediums or 2 high risk. So, and those are defined on the website. And the other thing was there was some thought that perhaps these performance improvement activities would qualify for the physicians to meet some of their continuing medical education requirements. This did not go through, and so this is not going to happen. So you will not get any CME, so you'll still have to do your continuing medical education on top of that. And as I said, cost, which was originally going to be 10%, is now not going to be submitted variable in 2017. However, Medicare will be looking at it, and they'll be calculating it from your adjudicated claims. And then in 2018, it's going to go up to 10%. So let me stop there and see if there's any more questions right now. And I do apologize for all the people calling me.
We do have a number of questions. Some I will say for the end, and some I will ask right now. The first is, what kind of infrastructure is already in place and is additionally needed for practices to be successful under QPT and APM?
Yeah, great question. So number one, if you don't have an electronic medical record, you really need to get one in, because you will never qualify for APM if you don't have an electronic medical record. So just keep that in mind. If you're a primary care provider or an oncology provider, you really should be looking at patient-centered medical homes. If you're part of an ACO, you're probably going to be submitting data through your ACO, but again, you'll still have to sign up through your practice tax ID number to get involved, and you'll need some type of analytics program. So in most cases, you're going to want to do that as part of your patient-centered medical home or ACO participation. And that's pretty much a infrastructure that has to be in place if you're doing an ACO or a patient-centered medical home at the federal level. So these are the main things that you have, but probably for the most people on the phone, the biggest thing is if you haven't adopted medical records, you've lost out on the meaningful use bonuses, and now you're in the penalty phase, but the penalties for this are much greater than the meaningful use penalties ever were. Any other immediate questions?
Does each individual physician have to participate in the improvement activities, or is it a practice-wide initiative?
Yeah, well, the data is submitted at the practice level. So by submitting it, you're going to be submitting your data per physician, because you have to have patients on the other end that you're doing the practice improvement with. So even though you're submitting data at the group level, it's going to be very hard to meet any of the thresholds if you have physicians in your practice that have a denominator and a numerator of 0. So I don't see mathematically how that could work out unless you have a situation where one doctor is doing 90% of the patient care and another doctor is doing 10% of the care. Mathematically, you could make that work, but any doctor who's doing a significant percentage of care, if they don't participate, it's going to make it very hard for your practice to make it. But again, it's about data submission, not participation. But there would be a few exceptions where a part-time physician might not have to participate. Okay, so as I said, most people will want to begin January 1st. But if you really are not ready to commit, then October 2nd of next year is really your drop-dead date. And if you don't sign up for this program by October 2nd, you are guaranteeing yourself a 4% haircut on your Medicare reimbursement in 2019, and there'll be no going back from that. And remember, you have until March 31st of 2018 to actually submit your data. But again, you're talking about future payments. So if you're a physician who's retiring in 17 or 18 and you're definite that you're going to retire, then you could technically not participate in this program. But if you plan to be in practice in 2019, you're going to be hurting for certain if you don't participate in this voluntary program, unless you're excluded. So you've got 4 choices as a doctor. You can choose not to participate, and you're going to take a 4% haircut in 2019. You can submit test data. In other words, you can do and to do test data, you have to submit 1 quality measure, 1 improvement activity, and there's a few points that you have to be able to get. I think I have that on a subsequent slide. You at least won't be penalized. So if you submit for something and you don't hit the threshold for a big bonus, at least you prevented yourself from being in the penalty pool. You can submit for 90 days, and you can submit for any 90 days, but in most cases people will probably hold off and submit for the 4th quarter in the calendar year, and you technically might be able to get a small bonus if you submit some data, but there again is no guarantee, but at least you won't get penalized. But remember, there will be some people that will be going for the full 4%. So because it's budget neutral, you run the risk of being not getting anything if you only submit for a partial year. And then there'll be the people that submit for the full year, all 12 months of data, and they should be going for as much benefit as they can, but most people will probably fall within the 2 to 3% bonus category, and only a very, very small numbers will actually get into the 4% bonus. So if you think about it, 2017 is where you perform, 2018 is where you submit your data, the rest of 2018 will be feedback given to where that data falls and whether you're winner or loser, and then 2019 is when it hits your reimbursement model from Medicare. So this is kind of a nice summary slide from the QPP website. So a key point, only got about 3 more slides here. So remember, this only applies if you're a physician participating in Medicare. It excludes physicians who are in their first year of practice or see a minimal number of patients, less than 25 Medicare office visits a year, or procedures that are qualifying, or do less than $30,000 of billing is typically the threshold. Your performance data in 17 will impact your payment in 19. You can choose to do MIPS or APM, but if you're already in an APM, you're going to want to try to stay in the APM. And if you're not doing anything, you're going to want to start submitting something to MIPS, even for a partial year. And most physicians will be in the MIPS and get paid for the 3 factors of quality, practice improvement, and the ACI, which is the meaningful use replacement. And again, if you don't do meaningful use, if you don't have an eligible electronic health record, you're throwing away 25 points on the top. So it's going to be very hard to get any bonus when you're excluding yourself from 25 points at the get-go. So there are 3 APM requirements for 2017. So you cannot be part of an alternative payment method if you don't have a certified electronic health record. As I said, even if you don't get approved for APM, you will benefit from the quality categories for MIPS, and you have to be in a risk-sharing ACO to be able to get the full APM bonus. And 2018 will be the last year for meaningful use penalties under the Medicare program. So if you're a physician or you're involved with a physician practice, I would say there's 5 things that you should be doing. First off, everyone in the practice should know about the quality payment program. And if there's not awareness in the practice, like I said, you are welcome to listen to this. You can go out to the website, and I've provided you 2 handouts. One is an executive summary from Medicare. The other is an executive summary from the American Academy of Family Physicians, which boils this down to a 5-page document for family physicians that you'll want to read, and it really gives you the fine points of the program. You'll want to do some kind of assessment to determine where you're at today, what kind of infrastructure you have in place. Are you already doing some quality improvement programs? Do you have a diabetes program? Do you have a weight loss program? Do you have a COPD program? Do you have a vaccination compliance program? You may want to take advantage of those. You want to put together a plan, and then you want to implement that plan as close to January 1st as you can, so you can take full year credit for this. But if not, don't do this any later than October 2nd, because a 4% cut on Medicare is going to be a pretty big cut, and it will only go up from there. And then as you get started, you want to evaluate how you're doing and adjust appropriately. But remember, you won't get any data back from your submissions, which have to occur by the first quarter of 2018. You won't get any feedback until late in 2018 for your penalties or bonuses for 2019. So in summary, a quality payment program promises payments tied to quality and other metrics. It will certainly disrupt current fee-for-service models for physicians. It creates new responsibilities for reporting. And as I said, we can anticipate unintended consequences to these changes that will be yet to be defined as we go forward with this. And if you do have any questions that we don't get to in the last 5 minutes, and we will hold on a little longer for those who are interested in questions, please feel free to email me at phil@medmorph.com. And you can visit our AdvizeHealth webinar for the past presentations on change leadership, which is very important when you're adopting change in your medical practice, and in population health, which is a new way to also improve patient care and perhaps do some of these quality programs. So with that, we'll go to the Q&A period, and Maggie, set them up.
Thank you, Phil. How can medical coders and billers best be utilized in the quality payment program?
Yeah, so the first thing that medical coders should do is really to become familiar with this program and help their practice manager or administrator understand what codes in their practice are actually the ones that are either going to put them into subject to QPP or excluded from QPP. And coders are probably the best people to have that data. And for people that typically see Medicare patients every day, I would assume that you're going to be impacted from this program. The ones that will be the real gray areas will be people that are in specialties such as anesthesiology, doing pain management, interventional radiology, interventional pathologists, and people that do low volume practices. So there'll probably need to be some numbers run. There'll need to be an awareness of what volume of your patients are at risk. And if the fact that you're doing coding, you probably have some stats that you can provide and can do some analytics to help your practice really prepare for this and create a strategic plan on how to approach this.
Thank you. Our next question is, what is considered the first year? For example, if a physician starts in July 2016, are they not eligible until 2018 since their first year is not over until July of 2017?
So that's a great question. I don't know the answer to that question. So you'll have to visit the website if you're in your first year of practice to really look at that. But because the fine point is, if you start in July 1st of 2016, I would be concerned that you probably will be needing to submit something by October, but it may say specifically first full year of practice. So that's a nuance that I did not research. I didn't even think about it, but I would say you're going to have to go to qpp.cms.gov and get the answer to that one.
Thank you. If anybody else has any other questions, you can send them to all organizers at this time. And I will answer one. Yes, these slides will be available in a PDF format that will be sent out with your CEU certificate, and that will happen in 3 to 5 business days. If you are interested in receiving those slides sooner, I've gotten a couple requests for that. You can also just send in a question with your email, and I'll be sure to send it to you as soon as I can. I don't see any other questions, so Dr. Phil, do you have anything else to add?
No, I really appreciate everybody's participation. We had large numbers on this call, and I hope the technology held up other than the YouTube video that gave me some challenges. And I really wish you luck with this. As I said, you really want to start with creating awareness in your practice about this. This is not something like ICD-10 that's going to be pushed off another year. It's not going to be impacted by the election. It is reality, so please get this information out to your folks. Download those executive summaries. If you're in family practice, you're going to want to leverage the American Academy of Family Physician ones. For everyone else, the executive summary from the QPP website will be a helpful summary rather than reading the, I think it's up to 2,700-page law. You really don't want to have to read that. But start with awareness, and don't panic with this, but don't put your head in the sand either. Ignoring this is going to cost a lot of physicians, all practices, a lot of money. So, and if you need help, I know AdvizeHealth will be looking at ways to help their clients with this program, and there are plenty of opportunities, and CMS has actually budgeted some money, but it's not very much for programs to help educate physicians. So there'll probably be some more videos and things that come out that you'll be able to leverage for awareness in your practice. So check the QPP website, and everything I talked about, you can go there and drill down and get further detail. It's a really well-designed website that is very informative, but you do have to do a lot of clicking to get down to all the information. So I hope I did this justice, and hope I didn't mislead you on anything. But thank you for participating, and I hope that you have a good implementation of these programs. Maggie, you want to close with a summary of AdvizeHealth again?
Yes, thank you. AdvizeHealth is an audit and advisory firm, and we do offer monthly webinars and newsletters that provide coders and billers with CEU credits. We offer 30 of those a year, and we are actually offering our next webinar on November 10th at 2 p.m. Eastern Time, and that will be titled Double Down on MACRA, and that will be especially of interest to providers who are looking to leverage that program for their benefit. That will be presented by the former president of the American Medical Association, Dr. Robert Waugh, and you will also receive a copy of that presentation at the time of the broadcast. If that is all we have for today, I hope everybody has a great afternoon, and I will be sending out your CEU certificates and PDFs in the next 3 to 5 business days. Thank you, everybody, and have a great afternoon.